Welcome back to our part 3 evaluation and management coding with Miss Melanie, where we're going to be looking at the medical decision-making details. For our video today, we'll be focusing on the different elements that go into medical decision-making and how to determine what constitutes as a complexity of problems, a level of risk, and our meat and potatoes, all the data and the elements that are required for selecting the level of complexity. So let's go ahead and get started. I'm going to go ahead and share my screen here. Okay. And so for today, we're going to use a couple of tools. The first one I will be using is 3M, and we're going to be looking at, through 3M, actually, the CPT Assistant that was published May 2021, page 8 through 10. So this is one of the amazing tools that 3M provides. They have the AMA, clinics, CPT Assistant, all kinds of details that really give us the meat and potatoes of our medical coding. In this particular article, they went in explaining the definitions of E&M guidelines. This is found when I go into 3M and I'm selecting an evaluation and management under medical decision making. This is the May 2021 reference here. So if you're going through the encoder, you'll get to that point at some point. And of course, it kicked me out as I show you, naturally. But we're going to stay here on this page, so never fear. All right, so here we have the first questions that we're looking at are really about the test data components. So you'll remember from our little scorecard earlier that we had over here, I'm just kind of erasing some of these highlights. We had over here our problems, our data, and our risk, right? So those are our three elements of medical decision making. When we're looking at the amount of complexity of data to be reviewed and analyzed, and they have this nice little phrase here with this little star. Each unique test, order, or document contributes to the combination of 2 or combination of 3 in category 1 below. Now that's not confusing at all. So when we go in here and we say, okay, ignore the code sets for a moment and focus just on this column. Under a limited or low level of medical decision making, the requirements for category 1 say it must meet the requirements of at least one of these two, so category 1 and category 2. And in category 1, to meet that, you have to have a combination of 2 of these 3 bullet points. And so you have to read through that. So review of prior external notes from a unique source, review the results for each unique test, or ordering of each unique test. Okay, so any combination of 2 would mean any 2 of any of those 3. So if there's 2 unique tests, then that will meet for ordering of 2 unique tests, whereas review of prior information. So this is where it gets really questionable, and providers who are not coders tend to go to their coders and say, how do we identify this? So in the medical decision-making guidelines and the tools we have from 3M here, they tell us under these definitions that they are looking specifically at a unique test as defined by the CPT code set. Okay, and they have some examples that are thrown in here. We're going to look at those here just a moment. So something important to keep in mind, however, in the world of laboratory and pathology, and for those of you that are taking this class with me, we've covered this, so you're familiar at this point. There are things called panels, and those panels have anywhere from a couple to several unique lab tests built in to the particular panel that is done. This is no different with other services that have bundled conditions. So you may have like a radiology where they have various views, and there's one code that captures all views, or there may be several codes that captures each individual test. So the important thing to keep in mind here is that we need to identify test based off of how it would be coded in the actual CPT code book. And so that can be kind of a challenge for anyone who is trying to count those test elements if you're not well versed in what goes into laboratory. Okay, so to make it simple, anytime there are multiple tests, so when you have multiple tests, you may have like a blood count. I think it talks about this somewhere in here, but you may have blood count with differential. Here we go, a CBC with differential, incorporating individual tests of the hemoglobin, a CBC without differential, and a platelet count. So those are 3 individual tests. However, because they have a CBC panel, they're going to be only counted once. So you want to keep that in mind when you're looking at what is a unique test based off of what the provider reviewed or ordered. Okay, so that's the first thing. And testing does not just apply to laboratory, but it will also incorporate your radiology services, as well as some of your services from the medicine section of your CPT code book. Okay, so when we go back here, there's a couple different things. You have review of prior notes, review of each unique test, as well as order. So some questions have asked us if we order the test and perform it and review it on the same day, does that count as 2 elements? That actually does not. So each of these orders or reviews cannot be done on the same date of service. So this is meant to give the provider consideration for their time and their efforts that they will be doing after the visit to follow up on those tests. Anything that's done day of service, especially if it's billed separately, that is going to be captured in when it's billed. So if they're doing an EKG on the same day, that sadly will not be part of this, but if they order an EKG to be done at a later time, then they will get elements here to count as part of their time and consideration. Whew, that's not as clear as mud. I don't know what is. The next area that you could look, so you have 2 categories and you have that nice little or here, right? So assessment requiring an independent historian. This is one of the most simple areas to capture, and I see a lot of times in documentation where it's not. In order to capture this, the doctor has to document who the independent historian is and that it was required for them to understand what was going on or that the patient needed them. So in cases where you have children, it needs to say who is providing the information, mom, dad. In cases with adults with dementia, you may have a caregiver. If it's not documented in there, we unfortunately cannot assume anything, even for young children who probably cannot speak their own history. So keep that in mind when looking. Now we understand a little bit the different tests and we make it confusing again. So we're just going to keep confusing it. We get to the moderate, and you'll notice this is one of 3 categories. So this can be any of these 3. You have that nice little or here and a nice little or here. Our category 1, however, pay close attention to this. So you remember here, any combination of 2 of these tests, correct? We're going to remove some of that highlight here. When we get to a moderate level, it's actually going to look at 3 of the following, and you have a couple more options here. So they've built in that category 2 from the previous one under category 1 for moderate level, and then each review of a unique source for notes, each review of a unique test, and ordering. So those are all the same, but you have to have 3, not just 2, to meet this moderate for category 1. Now, because of course, CPT coding is always broken into many pieces, we look at the next part. An independent interpretation of test. What is that? So this is a time where a provider receives a test with the report or without. So they've done, say they did labs and they want to look at the pathology information, and they look at the, let's say it's a tissue sample that they look under the microscope themselves. That would be an independent interpretation of that tissue sample. Or if they are looking usually at radiology or EKGs. Now, they cannot, this is so important, they cannot separately report that test. So if it's an EKG in their office, bills it under their name, you cannot count that towards the E&M. We only count that if they're looking at something that's already been done or is being done by someone else within within the patient's care. So you'll also notice here it's another physician or other qualified healthcare professional, okay? So not looking at their own previous test. Now that independent interpretation, you'll see this a lot when you have patients that are sent out for x-rays, where radiology has done the x-ray, a radiologist has reviewed and provided back the results, and the provider wants to look at it and make their own interpretation or compare it to another x-ray that maybe they got that same day. And then our category 3 here, the discussion of management or test interpretation. And so this is outside of the actual visit where the provider will go and make a phone call to another medical provider to ask them their opinion, their interpretation, or some other detail that's needed in order for them to understand the data that they're looking at. So those are different categories, and you can see just by meeting it under category 2 or 3, you will be moderate because you only need 1 out of 3 categories. Or category 1, any 3 of those areas that were previously under just low will be considered a moderate level of data. Now, it does get a little bit easier from there when we look at extensive data. This is really unique in situations that you're probably already going to be in a high level of medical decision making, if they're needing to do an extensive amount of data review, because a provider will need to meet 2 of those 3 categories. So they're reviewing at least 3 independent unique sources of tests, or their historian, or they're doing independent interpretation of those tests, so that comparison might count, and discussing it with another medical provider. So they have to have 2 of those in order for this one to count. And that really just means that they had to deep dive into taking care of that patient. Whew, take a breath. We made it through. So it sounds easy enough with a lot of details and a lot of review, but there's a lot of questions that have really come out over what's included in medical decision-making on the test data components. So I'm going to just kind of go over some of the examples we have here. These are examples that were provided after the guidelines came out in 2021, and in May of the same year, CPT assistant were getting a lot of similar questions. So some of the questions they receive are things like providers in the same clinic ordering a test, and then another provider of the same clinic reviewing said test. Now, in this particular instance, they do consider a provider from the same clinic to be part of the same clinic. So if one is ordering and reviewing it on a subsequent visit, they're only going to be considered based off of the visit that it was under. And they'll say here, let's see, Dr. A or another physician orders it and Dr. B reviews it during the follow-up. So who gets credit for reviewing the test results? Okay. So in this case, they've given us really clear indication. If their consideration is from the same practice. So if two physicians or other qualified health providers from the same practice, same specialty, would get a single credit for order and review of that test. Okay, so they don't get to order it and then review it and get double points. They get it once. And it does not matter in that case if it was done by a different provider. If, however, the tests were ordered at a different facility and the primary care provider, for example, receives the results and reviews it again. So you have something like urgent care or ER, and then they review it later. It will get counted for your doctor that is reviewing it after the fact. Another question that's looked at with medical decision making is the amount of data reviewed for previous notes. Okay, so when they look at prior notes, and they had that in here in just a moment. Here we have some examples. So you have your patient seen in the ED for chest pain, follow-up visit. The physician reviews a recent chest x-ray as well as x-rays performed 6 months ago to ensure there were no premonitory findings. And then would this be considered twice? Yes, it would, because they're looking at two unique sources. The next one that is of confusion is if a physician, and this one's one that we went over, if they order, perform, and interpret a billable diagnostic test on the same day, do they get credit? And we mentioned this earlier. If it's billable on the same day, the decision to order it and review it is part of that billable service. So they will not receive credit in the medical decision making for that. Now, this particular tool is available from 3M, but you can get it from the CPT Assistant. And as we mentioned earlier, that's the AMA CPT Assistant for May 2021. So those are available for coders to find. The other tool I'm going to show you today is an interactive scorecard from Novitas Solutions. So if you are in an area that utilizes Novitas for your medical coding, they've put together this really awesome interactive score sheet. The interactive score sheet allows you to come in here. So you go to novitas-solutions.com. Select where you're from. So if you're in one of these areas here, you can utilize this. If you're not, still feel free to use it. I find it to be helpful no matter where you're at, but make sure you're checking with local billing guidelines if you're coding and focused on billing as well. Now here, I'm just going to go ahead and select New Mexico because that's where I'm at. And I'm going into evaluation and management, interactive score sheet. So that's how I get there. And what I want to do is I want to use this tool to build my code. So you remember we had in our last video a patient with hypertension, hyperlipidemia, and diabetes. And we said in the last video that they reviewed recent lab tests. Now let's assume that they had an A1C, a metabolic panel, which we'll cover for a lot of details on all of their labs that they need pretty much. And let's say that they're coming in after being seen by another provider. So there was a review of previous notes from the previous provider that had prescribed medication. All right, so that's our patient here. So they have hypertension, hyperlipidemia, and diabetes. Now, we already know from our part 2 of this, I'm just taking out all those highlights because we're going to use this. We know from part 2 that if they have 2 or more chronic conditions that are stable, they're going to be considered a moderate level of problem. And if there is prescription drug management, they are going to be considered a moderate level of risk. So we already know that, but we're focusing right now simply on this test of data. So let's look at that, okay? Now we can come in here and we can say ordering of each unique test. There's a metabolic panel and an A1C, and so that does meet a category 1 here. When we come down to category 1 under moderate, we have to have a total of 3. So we only had 2. So we did not meet for 3 here. So we cannot say it's a category 1. However, if they are looking at unique notes, and I should have highlighted that here as well. Okay, so they didn't order. Let's go ahead and delete that. They reviewed. There we go. And it's actually 3 here because you have further notes from the previous provider and 2 of those lab tests. So they will meet a category 1 under both limited and moderate. So the higher level always outweighs the lower, but for that purpose. So this is how we would select it. We're still in the same level of service, but let's look at how our interactive tool will help us select that. Now they're going to ask us some questions each time we use this. Did we document the services? Yes, I wouldn't be coding it without it. I'm going to give them a test patient for today's date in the office or other outpatient, and they are coming in hypertension, diabetes, and hyperlipidemia. So we're going to hit continue here. And you'll notice a few things, questions that we've had in previous parts. So service type, are they new or established? Well, let's, for this purpose, say that they're new because they were coming in from a previous doctor. Are we billing based off of time? We're going to skip that part and continue on to our medical decision making and say it wasn't documented. Now, they want to know the number and complexity of problems addressed. And you can see here, like, wait a second, that doesn't help me at all. But I love these little eyes here because they will give you all of the details pulled from that little scorecard the same way that we were looking at it. So now we can come in and say, okay, it was 2 or more stable chronic illnesses, so that is moderate. All right, so we'll select moderate there. The amount of data and complexity, and again, we have to make that determination. So we're going to come in here. Oh, we can see it up and down, just as if we were in the code book and looking at those guidelines. Okay, so again, we know that there was prior notes and 2 unique tests, so that's a total of 3, which meets the category 1 for moderate. And so we're going to select that one here. And of course, risk. They did have prescription drug management, but otherwise were just stable chronic illnesses. So if they hadn't had prescription drug management, we would not be a moderate level of risk, but because there's management here, we will. So we're going to say moderate. And look at this. The interactive code has been selected for you based off of those elements that we just selected. Now, of course, we already knew that because we did it ourselves here, but those are some of the tools that are available to you. Well, that is the meat and potatoes of selecting data. Now, the one piece that we didn't get to was looking at the very specific areas of risk. When we look at risk, it's pretty straightforward. I want you to think the golden rule every time. If it's not documented, it didn't happen. However, make sure you understand what exactly is the level of risk. So when you're looking at your diagnoses and you're looking for that documentation, make sure you understand some of those areas. Your high-level services are really going to need to present with a high level of risk during the current office visit, not based off of the diagnosis alone. One of the most common areas of risk that are misunderstood are when a patient has a chronic illness that is severe and potentially life-threatening, or is going to eventually be taking their lives. They will die from it at some point. It's important to remember that if the condition itself is stable during the visit, their level of risk is not as high, because they're not requiring emergency services. So they are considered stable based off of documentation. Pay attention to things like drug therapies that require intensive monitoring. So you'll have some of those with some of the medications that a provider may prescribe, and they need to have intensive monitoring to make sure that the patient is not taking too much or too little of an adjustable drug that's maybe changed a couple times a week. Something like a blood thinner might be an example of that. But more specifically, you're looking at some of those harder drugs that we really have to keep an eye on, chemotherapy drugs and things of that nature. When we talk about decisions to de-escalate care, this would be one of those high levels of risk based off of a poor prognosis. And what that means is the patient may be going on to hospice care or palliative treatment because the condition itself is not going to get better and they no longer want to continue progressive treatment. These are all some very serious level diagnoses and treatment options, and those will, when documented properly, justify that high level of risk. Be wary of selecting too high when you're looking at those because you want to make sure that you understand exactly where the patient is and again on the date of service. That's it for me today. Make sure you come back for our part 4. Will be coming out next week, where we look over the elements of time and how to build your office visit documentation specifically to properly document that time. If you like us and you want to comment, please feel free to do so. You can subscribe, and we'll talk to you next time.